On this episode of the ASC Podcast with John Goehle, we discuss the latest news and information, including the proposed CMS ASC HOPD payment rule for 2022, and in our focus segment, discuss leadership development with Laurie, Roderiques, and Geier.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. This episode is sponsored by Surgical Information Systems, providing cutting-edge information solutions for surgery providers and ambulatory healthcare strategies, the nation's leading regulatory compliance resource for ambulatory surgery centers. For more information about our sponsors, please visit our website at ascpodcast.com.
Welcome to episode 136 of the ASC Podcast with John Goehle for July 20th, 2021, recording from our studios in Spencerport, New York. This is Susan Cronkite, Chief Researcher for the ASC Podcast with John Goehle and Senior Nurse Consultant for Ambulatory Healthcare Strategies. Joining me is John Goehle, the owner of Ambulatory Healthcare Strategies, recognized as one of the nation's leading experts in the ambulatory surgery industry. Mr. Goehle is the author of over 10 books on the ASC industry and a frequent industry speaker on regulatory, accreditation, and finance issues.
So I know this has become common for us to say this, but we have a big week ahead of us here. We're recording on actually Tuesday, and later this week, on Friday, we have our annual Infection Control Conference. That's a live conference on Friday, July 23rd. And this is Infection Control 101, which is meant to be kind of a introductory infection control conference, or the type of conference that people need in order to demonstrate that they've been trained in how to do infection control oversight in an ambulatory surgery center.
Yeah, very important right now, especially.
Right, exactly. And Sue, you and I and Laurie Roderiques are going to be working on it. Laurie does most of the content there since she's the certified infection control coordinator, but we have an inimitable style, don't we, for our conferences, which allow us to not, kind of stay away from that whole webinar format where we have more interaction, where we talk among the three of us during the conference, and of course invite lots of conversation with our audience. We have quite a number of people signed up for it, so it's actually going to be quite excellent. Well over twice as many people as we had for last year's conference in April of 2020. And if you can't make it on Friday, you still have time to sign up. If you listen to this recording before Friday and Monday, I should say, there are two separate conferences here, so you still have time to sign up. But if you're not able to attend live, we will have a recording available also. The price will be the same for the recorded or for the live conference, but that'll be available within the next couple weeks. This conference, the one in 2020, was by far our most popular virtual conference that we presented all of last year.
Now, do you have anybody signing up for just the 201? Is there anybody you recommend doing that?
Yes. So usually what we find is in the beginning, for example, we actually had more people signing up for 201, and then for whatever reason it shifted. 201 is kind of designed for those people that have already gone through like an introductory infection control course, and don't need the IPCH credits, for example, if they just need, 1 days of IPCH credits. But if you're an infection control preventionist, you need to demonstrate not only that you have initial training on infection control oversight, but you also have ongoing training. So the purpose of our two conferences, which we will be doing every year from here on out, is that we revise our regular conference that gets people prepared to be an infection control preventionist. And we also have the update that they'll be able to use to demonstrate ongoing training in this area. So,
and to get those credits, which is really important.
That's another really big deal here, is that anybody that is CAPE certified, they're going to get 7.5 credits for 101 and 7.25 credits. So you can actually get almost 15 credits between the two conferences, which will go a long way toward getting the number of credits that you need in order to maintain your certification. Laurie's working very hard on this conference. She puts a lot of time into it. She's always so nervous, and yet she does so well. I don't know. It's so funny.
She just comes off as so comfortable and likable. I love seeing her conferences, but
and people love her, and she's got a great sense of humor, which you kind of need when you're talking about this stuff. So, and by the way, for those of you that are CASC certified, we are also offering the same number of AEU units on clinical care. So again, you'll be able to get it for your CASC certification or for your IPCH credit certification. So for more information, go to ascpodcast.com or follow the links that I'm going to include in the show notes. And then, Sue, the Administrators Bootcamp is coming up very fast. And that the Administrators Bootcamp that we did in January was very successful.
Yes.
We have as many people signed up for this one, and we're still about 4 weeks away from the conference, I think. So we fully expect it to sell out. We did increase the number of people that we're including in it for the August cohort,
and we get more and more participation. I think it gets better each time.
Well, it's because you get better at it. That's one of the things you've been very good about, coming up with ways to keep people engaged. And you had this idea with the boot camp in January that we unfortunately didn't do until the last day, where we just brought everybody in at breaks, and that was very successful. It worked very well with the Director of Nursing boot camp. We will have another Director of Nursing boot camp later on in the year. I don't have a specific date for it, but we will be announcing that shortly.
And we mean by turning on the Zoom camera,
right,
by bringing everybody in, just so everybody can see who's there. Because I guess you can't even see the list of participants.
That's
otherwise.
Correct.
So, people didn't know. I think they were intimidated, didn't know if there were a whole lot of people or whatever. And it just makes it better the more people can.
And you don't have to turn the camera on. Like, not everybody turned the camera on, or not everybody spoke. But it's an option that you have. And one thing we should point out for both, for all of these conferences, is that if you can't make it for part of it, and that's the real life, the real life is that you're probably doing it during your work day and you have to go away. The good news is that in all of these conferences, you do have access to the recordings for 6 months afterwards.
Yep.
And then, Sue, we're going to be doing a focus segment today on leadership in the ASCs, which I think it was back in May. Laurie, Roderiques, and Geier, you and I got together. I think you had to leave, though, so I don't think you were actually included in this particular conversation that we're going to have in our after our break. But we got together to talk about leadership in the ASC, which really ties into what we're just talking about with these conferences that we're doing in the next couple months here. So we're very excited about it. But we need to announce something that we just haven't really announced, and that is our dear friend Ann Geier, registered nurse and very well known in the industry, joined Ambulatory Healthcare Strategies back in June of this year. And we just haven't made a big deal about that. I mean, I think everybody knows it by now, but we thought we would kind of mention that during the podcast here. So her debut is going to be in this podcast during our second segment. And so I just also wanted to mention that we are working on 2 other projects right now. A medical director conference, which we hope to be later this year. It probably will be on a Saturday, since we recognize most physicians just can't get away during the week. So it'll be like a 9 to 3. It's not going to be a full day, but it'll be and it'll be the same type of format where, we'll have a lot of interaction. It'll be recorded, so if you can't be there the whole time, you'll still be able to have access to it. We've had a lot of feedback from our clients who we've asked if they would be interested in this, and I expect it'll be a very popular conference also. And then we are in the beginning stages of developing a leadership conference sometime later this year, maybe early next year, depending upon the timing here, which will be, really focused on leadership type discussions. While there's going to be an education component to it, the leadership conference is meant to be an interactive conference where, we get together leaders in the ASC industry, leaders of today and leaders of tomorrow, to discuss issues that are coming up in the future of the industry. So we're very excited about that. So probably the biggest piece of news is, of course, yesterday. We're recording this on Tuesday, but on Monday of this week, the CMS released the proposed payment rule for 2022 for ASCs and HOPDs. But before we get into that, Sue, I did want to mention that on July 13th, a couple weeks ago, the CMS released the proposed rule for the 2022 Medicare physician fee schedule. And unfortunately, this fee schedule called for a reduction of a little more than 3.5%, or actually closer to 3.9%. most of the decrease is because of the expiration of a 3.75% decrease due to the conversion factor that was supposed to take effect at the end of 2021, but it was stopped by Congress as a result of the pandemic. So while this doesn't directly affect ASCs, you're going to find an awful lot of discussion out there from physicians who are quite upset about the reduction in their fee schedule, especially given the inflation that we're all experiencing right now. I think I filled the tank up in the car the other day, and it was over $50, and it wasn't even empty. So certainly we know that inflation, especially in healthcare supplies too, and the money that we're spending on PPE now, I mean it's had a huge impact on our bottom line in terms of the cost of supplies, as well as seeing it in our own lives. So I'm sure the physicians are not happy about that, and it's going to put pressure on them to seek other revenue sources, which would include trying to get more profits out of the surgery center. So just keep an eye on that. So as we mentioned, the 2022 proposed HOPD ASC payment rule came out on Monday, the 19th of July. It's a little bit late. Usually it comes out at the beginning of the month, but it is earlier than it came out last year. And I guess I should point out that annually, just a little bit of background here, Medicare sets the rates for the following year, and they make a proposal in July of each year, and then they finalize the rule in November. So what we're seeing here is the proposal for the 2022 rates. It's not a permanent, it's not set in stone yet, but it sets the tone for the conversation, and we will have an opportunity to make comments to CMS about this.
And I'll talk about the non-financial aspect of this. So it's important not only for the payment, but also because the payment rule sets other regulatory requirements, like the Medicare quality reporting and Medicare allowable procedures. So those are two big ones.
Right. So I think a lot of times people think that this payment rule is only for the finance people in our surgery centers, but it does impact all of us, and it really is important. And I think, Sue, that's one of the challenges that we have. In the podcast, I think we've been doing a good job lately of trying to show both the finance side and the regulatory side here. So let's start by talking about the payment rate update. Now, it's important to remember, too, when I tell you how much the increase is going to be, because of the way the rate setting works, it's not going to be across the board. So you're not going to see all of your rates go up by 2.3%. That is the increase this year. You're going to see it go up by an average of 2.3% across the board. And that's going to be dependent upon the procedures, the specialties, and things like that. CMS is proposing to update the hospital outpatient payment rates that as long as they meet the applicable quality reporting standards by this 2.3%. And it's based upon a projected hospital market basket increase of 2.5%, reduced by a 0.2% decrease for productivity adjustment, which they make every year. So 2.5 minus 0.2 comes down to 2.3%. Now, those of you that listen to the podcast regularly know that in 2019, CMS finalized a proposal to apply the same hospital market basket update to the ASC payment system rates.
Which is a good thing, right? That was something you had hoped for.
Because the old ones were based upon the cost of living adjustment, which is urban cost of living adjustment, which is really for, food and, things that we use in our home, not what we use in the healthcare field. So this was a very good thing. And it's an interim program. I think we're in year 3 of it right now, an interim period of 5 years. And CMS is therefore increasing our rates by that same 2.3%. Now, it is also important to note that the proposed update applies to ambulatory surgery centers that meet the quality reporting requirements. So we talked in May about the importance of doing all the filing of the Medicare quality reporting measures. Hopefully everybody was able to do that. I know it was very challenging to try to get into the system, but once you got into the system, the reporting was actually not very difficult. But if you did not report, then you would not be eligible for the full amount of this update. I think they reduce the update by 2%. So instead of getting a 2.3% update, you would get a 0.3% update. So that's one of the big incentives of making sure that you file your ASC QR, your Medicare quality reporting data. Now, interestingly here, too, is because of the pandemic, CMS proposes to use the 2019 data from the hospitals as part of the rate-setting methodology instead of the 2020. And this makes perfect sense because the data that was reported in the hospital cost reports for 2020 is going to be dramatically, very unusual, shall we say, and probably not very representative since the types of cases they were doing during the year weren't representative of what we normally do in a year. So I think it made a lot of sense for them to use the 2019 data. Now, some people ask me, well, why are we using the hospital data for doing the rate setting. That's because ambulatory surgery centers don't prepare cost reports unless you're in the state of New York. And though there has been proposals for doing cost reports, that has not happened. So the only information they have to adjust this information every year, or these rates every year, comes from the hospital cost report data. So, Sue, let's go through the various things that are included in the 2022 payment rule.
Okay, so first there's the elimination of the inpatient-only list. You might remember that as part of the 2021 final payment rule, CMS decided to phase out the inpatient-only list, but it's received a number of comments suggesting that it was not in the patient's best interest to do that. So CMS is proposing to halt the elimination of the IPO, or the inpatient-only list, and after clinical review of the services removed from the IPO list in 2021, they propose to add back all of the 298 services removed from that list in 2021 back onto that list beginning in 2022.
Yeah, so that really is not good news, I think, for most of us. I think we've been making the argument that the inpatient-only list is outdated, but the hospital lobby certainly went to bat and said eliminating that list is probably not in the best interest of patients. I do understand where they're coming from, but if you actually get into the nitty-gritty here, you'll see that it was done very appropriately. CMS stated that this change in policy would ensure that any service removed from the IPO list has been reviewed against Medicare's longstanding IPO list for criteria to determine if it is appropriate for Medicare to pay for the provision of the service in the outpatient setting.
Well, I just hope they're following the numbers and the data and not just who has a lot of money to lobby.
Yeah, exactly. Well said.
And furthermore, CMS is proposing to codify the longstanding criteria for removal of procedures from the IPO list to make clear in regulatory text how we will evaluate future procedures for removal.
So that does sound promising, assuming that we can trust that they're going to make some good decisions as they're going through that. And there is some language. I didn't get in. I mean, the whole regulation, the proposal is, hundreds of pages long. I didn't want to get in a lot of detail. But there is some proposals for the mechanism that they're going to use for updating that list, and that did look promising. So, Sue, this is the exciting part. This is the part that you spend a lot of time on, the Medicare ASC Quality Reporting Program update. Exciting only from the standpoint that there hasn't been a lot of changes over the last couple of years, but not so exciting from what they're doing.
So the ASC QR program, just a reminder, it requires ASCs to meet quality reporting requirements or receive a reduction of 2 percentage points in their annual fee schedule update if these requirements are not met.
And we have to remember, too, that the ASC Quality Reporting Program, which we use the initials ASC QR, is a pay-for-reporting quality program. And eventually, the intention of the program is that they're going to pay for quality. So that the quality measures that they're using will be used in the determination of what your future rate updates will be. Yeah. But since its inception, it really has only been a pay-for reporting and a not pay-for, not reporting. Meaning that, as we mentioned before, and as you just mentioned again, if you don't do the recording, you're going to get a 2% reduction. And remember, that 2% reduction permanently reduces the base that you're going to have moving forward. So it is important that you do this recording. I don't know that we can stress that enough.
So we're going to go through what some of those changes are.
So CMS is proposing to adopt one new measure. No big surprise here. So the COVID-19 vaccination of healthcare personnel will begin with the 2022 data collection. I'm assuming that this is similar to the flu vaccine program that had been done through NHSN before. We don't have any more data on it, or at least I haven't read enough information to know how they're going to do that collection. But that is something that I think we all expected, and certainly makes a lot of sense.
And they're going to make the reporting of 6 voluntary or suspended measures will be mandatory again. CMS is requesting comment on the quality measures for pain management procedures performed in this setting.
Yeah, so there is nothing yet with the pain management, but they did indicate in the rate saying that that's something they're going to look into. So CMS is proposing to restart the reporting of the ASC 1, ASC 2, ASC 3, and ASC 4 measures beginning in 2023. And they're going to be doing it apparently using a web-based submission system, similar to the system that they're using for the other measures, instead of the claims-based methodology that they used before.
Okay, just to remind everyone, ASC 1 is patient burns, ASC 2 is patient falls, ASC 3, wrong site, wrong side, wrong patient, wrong procedure, wrong implant, and ASC 4 is hospital transfer or admission.
Right. And that reporting was done for quite a number of years. So many, I know many organizations actually didn't stop the reporting. It was still voluntary. Yeah. So I'm sure that hopefully everybody still has the processes in place. They just have to restart it.
And they really weren't finding big issues. So that's, I think, why they held off on it.
Well, and I think that's one of the reasons we had mentioned this when they did away with it, that we were kind of sad that they did, because those are things that were particularly good and that it was good to have those statistics out there.
Now, a difficult one is now they're going to require, or they're proposing to require, that ASC 11 cataracts improvement in patient's visual function within 90 days following cataract surgery. They're proposing that becomes mandatory beginning in 2023.
So this is going to be quite problematic, I think. It is currently voluntary. I don't know if certainly none of our clients voluntarily reported this because of the difficulty of doing this. The challenge is, especially for centers that, I mean, if your surgery center is owned by the practice, you have ready access to this information, but maybe not, because you do see the patient, a couple days or a day after the procedure is done, but you don't necessarily see them 90 days later. Yeah. So that information is going to have to come either from the primary care doctor or an ophthalmologist or optometrist, whoever else is doing that testing afterwards. So I don't know how this is going to work. And, you and I were talking about this yesterday. The problem with this is, again, this is a quality measure that's meant to determine and to impact our rates. I don't think it's fair that let's look at it this way. Yeah, either way. I mean, that we should take credit for the fact that the patient's visual acuity improved, because it was the physician's skill, the skill of the physician that resulted in that. He should be getting rewarded for it. We should be given better pay for the environment, which is what they're paying for as part of that technical component. So that I can understand. We treat the patient well. The nurses do a great job.
Infections can be tracked.
There's no infections. Exactly. Those are the types of things that we should be rewarded for. But the visual acuity is clearly on the part of the physician who actually performed the procedure. So very disappointing. We'll see if I know the ASC Association is going to work on this, is going to put some comments in, and we'll talk about that at the end here. So let's hope that gets changed.
And then they're proposing to implement the OAS CAPS program beginning in 2024, which we've talked quite a bit about. So that's the Outpatient and Ambulatory Surgery Consumer Assessment of Healthcare Providers and Systems.
And the name of it is just somewhat smaller than or shorter than the amount of time that people will have to spend going into this. So the original versions of this included well over 30 questions that would be asked of every patient. And of course, when we put together, patient surveys, we try to keep people down to 5. I mean, I think it's too many when you do 10.
I know.
Yeah.
I know.
And of course, what you want is you want to get the good comments, and you want to get the comments that can help you to improve.
Yeah, and you can always start with general things if you can. And then if they see an area that's of concern, then maybe delve in a little bit more. But to start off with 30 questions.
Or more. It's well more than 30 questions. Yeah. And it tends to encourage only surveys of disgruntled patients due to the excessive number of questions. We're passionate about quality improvement. So I do try to take the surveys that I get. Like every time I take the car and I try to fill out those surveys. But I get very frustrated when, they say, this will only take you 15 minutes. And then you get into it and there's 20 questions. I had a survey the other day where, I finished like 10 questions and then it said, yes, you're eligible to take the survey now. I'm already done.
Yeah. But boy, if you were mad about something,
you
probably would have gone through. I'll put in a complaint here and there, not very often, but if I have to. And I always think when somebody, I get really good service, I always tell myself I'll say something. And sometimes I do, but it's just that motivation. Unfortunately, human nature, it's just not there as much.
The other challenge with this is that you will have to pay an outside organization to do the surveys. There are a number that are already approved by CMS to do this, but this will be an added cost. I believe it's at least, I think I've been hearing numbers in the range of $5,000 just to start it. So this will be another cost factor. This, we know we will not be able to stop. I mean, it's something that will have to be implemented. Yeah. We always knew that it was coming. I think you and I predicted it actually on the podcast a couple weeks ago that it would be included.
But I feel like it's also going to take away from, if you have this being done, is anybody going to also take your 5-question survey that you want to do from the center where the issues and really are getting, I believe, without seeing their questions, but I feel like the things you can design for your own center are going to get much more applicable answers and things that you can address and fix.
Which you can take
I think we're
action
going to lose good information and really just annoy our patients.
Well, the rate of compliance, I think, is also going to drop. Not that we have great compliance in all centers right now anyway, but I do think that you're going to find fewer people responding to these surveys. Yeah. So we really encourage you to follow the ASC Association at the ASCassociation.org website. They are going to be taking the lead in responding to our concerns about this payment rule. So if you are passionate about it like we are, I really encourage you to visit their website. And then I believe they're asking for suggestions for people to write in their comments about this. And the more that we can provide our feedback to CMS, the more likely we will see some type of action on this. So we are so passionate about leadership in the surgery center and the challenges that we've all been having with finding nursing leaders, with administrators, business office managers now, has been quite problematic. Well, the main reason that you and I created the 2 boot camps, and hopefully we're going to do a business office manager boot camp also in the near future. So during our retreat in May, Ann Geier, Laurie, Roderiques, and I had an opportunity to sit down and just kind of open the mic up and talk about leadership. So we're going to take a short break and we'll come back and we're going to include that interview here. Thank you for being a loyal listener of the ASC Podcast with John Goehle. But did you know that you can enhance your experience and support the free podcast by becoming a patron member? Patron members have access to ASC Central and add-on service at a very reasonable price. Patron members have access to our regular drop-in virtual meetings where you can discuss issues that you are dealing with in your ambulatory surgery center with the hosts and other members. Members also have access to valuable member resources, including a document library with a growing list of resources, including the rules and regulations, guides to maintaining compliance, example policies and procedures, infection control resources, example risk assessments, example committee and governing body minutes, and over 60 disaster drill scenario kits and example forms and checklists. Members also have access to some of the virtual conferences that we have presented, including the Provider Credentialing Conference, which we offered in December 2020. It's a New World Conference in 2020. Infection Control in-Service to meet the challenges of COVID-19, and the ASC Mandatory Education Program, which is a valuable resource for annual education for your staff. Membership helps to defray the cost of producing the podcast, including the research staff, travel costs to conferences, equipment costs, and production costs. For more information, you may visit ascpodcast.com. To become a member, visit ascpodcast.com. So I'm here with my dear friends, Laurie Roderiques, who is the Director of Clinical Service for Ambulatory Healthcare Strategies, and Ann Geier, who happened to be in the area and stopped by our studio. Ann Geier is the Chief Nursing Officer for SIS. Ann, what do you think of this studio? Actually, Laurie, you were here before, so you saw the studio before. What do you think of this?
Well, I had to come see what this was all about because, as some of you have heard me say before, John was on the leading edge of virtual presentations when COVID hit. He was the best prepared and started out doing virtual conferences, full-day conferences, 3-day conferences, podcasts, well before many, many other associations picked up on how to do it right. So I've always been curious, and I come in. Like. You all should see the amount of equipment in his studio. Yeah. And there's computers everywhere. There's green screen behind our back.
It's just an 8x8 room.
Yeah, it's not a big room. I mean, and it's even got a camera that focuses on Rosie, who has her own bed under here.
The Rosie cam.
It is absolutely incredible. But no. It's I'm going to have to take some pictures to show Carl when I get home because it's really pretty darn incredible. And the soundboard you've got in front of you, I don't know how you learned to use all this stuff.
Well, I was that geek in high school.
I can't tell.
You still are.
Still am. So the board that you have in front of you here is very similar to the boards that I used in high school when I was running, doing the high school plays. Well,
that's what it looks like. It looks just like that.
The funny thing is I used to rent these boards for the amount of money that I paid for them, and that's how much technology has gotten to the point. I think I paid $300 for that. I bought this one used. It is time to replace this, but
well, we're looking at 4 microphones, all on pedestals that are movable. I think you have 8 microphones, though, right?
Yeah.
I mean, y'all, this is listen to my southern y'all. It's very obvious that John's done it right, and he has good equipment, and he's doing a good job with this. So you're to be commended, and I'm happy I got to come by here and see it.
Well, I'm so happy you're here. And that really gets to the heart. One of the things that we had to do with the podcast and in our company, Ambulatory Healthcare Strategies, and what you've had to do as working with SIS, is we had to pivot. We had to change from the way that we were doing business before. And just earlier today, I did the keynote for the New Jersey Association. And one of the things I talked about is how we as an industry were best prepared for doing that pivot, because we're used to having to change on a dime because our doctors demanded it. And that's why we're in this industry. So I thought we would just start off this conversation by talking a little bit about the types of skills that we need to have. This whole conversation is really about leadership and development, staff development, things like that. It's a broad topic. We'll be talking for 45 minutes, I'm sure, and we'll still not cover all of it. But so I just wanted to kind of open that up as our first discussion is, what do you think? How do you think we have done during the pandemic in pivoting, and where do you think we need to go from here?
I think some people have done better than others. Everybody is not a natural leader. So you may have found yourself in a leadership position, and you were kind of coasting along pre-COVID, and then you had this hit, and nobody expected it. We weren't prepared for it. We didn't have pandemic policies. That's where leadership steps in. If you're a leader, you demonstrate initiative. You think quickly on your feet. You know how to do research. You know how to network with friends. You know where to go to for help. I say that because those are all qualities you need as a leader and a manager in a surgery center. And it was one reason, and we're not held down by bureaucracy. Right. We have a very flat organizational chart. So usually the administrator, whatever your title is, executive director, chief operating officer, administrator, whatever your title is, you know that there's not a whole lot of structure above you. Right. The doctors are looking to you to make the decisions, and you inform them of the decisions, and they back you up. But you better have good reasons for doing it. And then COVID comes along. And because we didn't have the bureaucracy of other institutions, example, hospitals, who it's like they say a camel is a horse put together by a committee. So you've got decision processes that go on forever. And even with COVID, when they were being forced to make quick decisions, they couldn't make them. And I think that that's some of the problems that came about with occupancy, with equipment, with all kinds of things. We just took what we had and made it work. Now, we weren't given the option of staying open at the beginning, so we dealt with that. Then all of a sudden, HR came to the forefront because you have all these employees. You can't be open. What do? Yeah. We pivoted. We didn't lay them off. For the most part, we furloughed them. Then we had to pivot again because if they're furloughed, you can't do any training. You can't do anything with them. You can't communicate for anything with the ASC. Now you're allowed to reopen, but they've been furloughed. Now they have to have had the complete training on COVID. They have to be current on all their informational offerings. What did we do? We did it. We did it by the rule. I mean, nobody cut corners on that. Right. I love this industry. That's why I'm so passionate about it. And we have people in management and leadership positions in this industry that are stars in the field, in my opinion. And they dealt with this in their own manner, sticking to all the guidelines, but they got through it. Yeah. And we're starting to see a light at the end of the tunnel. But if you're one of those leaders I'm talking about, pat yourself on the back because you deserve it.
Yeah. If you're not going to get it from your own, unfortunately.
But if you're one of the leaders that wasn't able to do that, many of you are long gone. A lot of you have already left. John and I have talked about this before. We lost administrators because they got overwhelmed and they didn't know how to pivot. They didn't know how to network. There's all these things that they weren't prepared to do. And they said, this isn't what I was cut out for. I didn't sign up for this. And they left. And so now you've got a center who's leaderless. trying to hire somebody during a pandemic, and it's awful. It's a bad situation. Or they're still there and they're miserable.
No, that's true. And the other thing, too, is that we've also lost a lot of leaders because they found that this was a good opportunity to retire.
Yeah.
And you know what? I won't tell you that years ago, when I worked in a hospital, the hospital offered a package for people to leave.
Mm-hmm.
And I believe they wanted to downsize what they considered their high earners, their top earners. And what they got was more than they ever bargained for. The number of people that had to leave on the same day, and a number of us, like in the operating room, that were brought back the next day as per diem.
Yeah.
Yeah, doing the same job.
Right, doing the same job.
Probably getting paid more.
And that was just, so you got to be careful. And I think COVID's given some people that that decision power that they're just walking away from it. And not picking on senior type people, but a lot of people in those positions have been in them for a long time. And we don't always think about grooming our own replacements.
Well, and I think some people feel that that's a threat, that if we are training somebody, if we're teaching them our job, then our job is in danger. And I think there's actually the exact opposite. I'm concerned. I always feel that the best sign of a good leader, best sign of a good manager even, is that they can leave and somebody is ready to take on their job and be, maybe they didn't do it as great. Maybe they're still learning from it. But the place doesn't fall apart when you leave. A bad leader is probably one who, when they leave, the whole place falls apart because nobody else knows their job. And we have to be prepared for, in the best of circumstances, some people have had to leave their positions now because they have to become a teacher now in their home. They have to stay home with
their priorities have changed.
Or they're having to take care of older and younger people.
Yes, absolutely. I had a physician tell me one time I'd been gone. I never took more than a week off at a time, but I'd gone to a meeting. So I may have been gone for 10 days total. And I came back, didn't get a single call while I was gone. My medical director came up to me and he said, "How was your meeting?" And we started talking about it. And I said, "I never get a single call." He said, "That's because you've trained your staff well." He said, "That's the way it ought to be, that they shouldn't have to be calling you for everything. And you've got them all trained." It went smooth as clockwork. So I was happy to hear that.
Yeah, no, it's a good way to take the temperature of your center. And then to take the temperature of your staff, because you know that they're going to follow through and do their jobs as you would expect them to, whether you are there or you're not there. And so now we're finding a lot of centers across the country, not just locally, that are having trouble getting that leadership back, or finding those persons that will fill the roles. And like you said, Ann, or John, you're not necessarily doing it the same way as the prior person, but you still need to have the same focus as in the goals and
you're getting the same
mission,
results.
Right.
Yeah, the
you
same
want to
results.
follow that vision, that mission of the center. How you get to it, we're all different. So everyone's going to be different on how they get there. So it's tough. And I think there's a lot of, I think there's a lot of nurses out there that are afraid to go into that role, because we're not trained that way. We're not trained in school to be leaders. Right. That's maybe, okay. I haven't been in school in forever.
Yeah, about 200 years actually.
Pretty much, yeah. So, maybe they are training nurses like that now, but we need leaders that can be both administrative and hands-on.
Yeah.
I don't know if either of you know Bill Duffy. He's past president of AORN. One of my close friends for years now. We've known each other. He's at Loyola now teaching in the master's program. And he did a survey of students, and he asked some of the industry experts about whether they would ever go into management. And overwhelmingly his students who were going into master's programs said, I would not go into management to save my life. I don't want those headaches.
Yeah.
They're looking to do something where they can function independently, like nurse practitioner, or go on to be a CRNA or whatever they're going to do, but they don't want management. And that's a bad sign for all of us looking for good managers. Right. I mean, he said nursing is going to run into a really serious deficit, or they go on and get their PhDs and they're going to do research. They're never going to work as a practicing nurse.
That brings up a very interesting point as we try to fill the leadership gaps. Heck, right now we're just trying to fill our staffing gaps. But leadership has become a major issue. I mean, that's one of the reasons that we at the podcast have, developed the two boot camps. We have the nurse manager boot camp, which comes up in the end of May, and then the administrators boot camp, which we'll be doing the second time around in August. And Anne, you have agreed to join us on the administrators boot camp, and of course, Laurie, you've handed me all the speeches that you're doing for it. Thank you very much. Now I got to read all of them. But
that's for the nurse manager.
The nurse manager boot camp. But that's a sign of the times. That's a sign of how important and what a deficit we have. We know that you're not going to learn in college how to do this. We know that we don't have the ability. I mean, it would be nice. I mean, better education would probably be, Laurie, you're the nurse manager at a surgery center, and you identify somebody and you spend 2 years of your life showing them everything. That would be far better than what we're doing, with a boot camp. Yep. But a good second choice is probably the only choice we have.
You're giving them information and knowledge that they may not get anywhere else. And I'm sure we're going to provide them with a lot of networking opportunities to share knowledge. I think that I fell into management. It was an accident, and I spoke at ASC on succession planning, and I told my story there. But I didn't think I'd never thought about being a manager. I never thought about ambulatory surgery, and I'm not going to tell the story here. We can do that on another podcast. But my nurses that wanted me to take this job as the manager of a new HOPD were convinced I could do the job, and I couldn't see it. So my advice to any of you out there listening to this that you think you might want to be a manager or a leader of any type, when there's a fork in the road, we know Yogi Berra said take it. Well, that's one way of looking at it. But always consider the implications of saying no. Mm-hmm. Because if I had said no at that time and not taken that job, I wouldn't be sitting here today. Right. So I wasn't sure I could do it. I was promised a lot of help, which now I am committed when I hire somebody to give them that training. And it's the best thing I ever did. So don't ever, and I counsel a lot of you. I call people that I help my mentees. When I have mentees out there that write me questions and want to know, should I do this? Should I do that? I said, if you don't do it, what are the implications? Because it may be a dead-end career. You may be stuck doing what you're doing now. Stuck as in if you love it, that's fine. But if you don't like it, you may have missed your opportunity because you had somebody that really believed in you that wanted you to move up. So as we're sitting here talking about leadership, look for people who have the potential to be the next best thing in a leader in your facility. Mm-hmm. I have trained so many people, and people will say to me, why did you give them all this training? Why did you send them to courses? Why did you do this? You're going to lose them. I said, I'm going to lose them anyway because they're not going to be happy and they're going to end up leaving. Whereas now, if they may be very thankful and stay, mm-hmm. or they're going to get a great job somewhere, and I was responsible. How good is that?
Yeah. Now, that's really a very good point, too, is that we have to take a much more altruistic look at this. It shouldn't be just self-centered where, we're developing these people so that they can stay with us, because ultimately that might not be the best route for them. And the more that we can prepare them for being happy in life, I think that they'll remember that, and they'll pass that message on to other people, and those people might be appropriate.
Well, people say to us all the time, my career path is to be a leader, manager, whatever. Or they say, I want to be who you are. I want to be like you. But my thing is we have such a flat hierarchy in surgery centers that there's no room for advancement. Unless I'm getting ready to leave, they're not going to get my job. So I can help them get to that position quicker if I agree to help train them, and I'm only doing them a favor. Right. Now, if I'm thinking of leaving, I may be training my successor. So it's a win-win for the center.
I think we also have to recognize that this, before, as we were sitting around the living room here, they're at my home, which is also the studio. As we were sitting around in the living room talking about this, I think I joked with you guys. I should have just turned the microphone on up there. We were talking about the next generations, and I don't want to get into, millennials and things like that, but I do want to talk about how things have changed, because we do have our employees of today are very different. And some of it is good. We have, I think there is a bit of a switch now toward more family orientation. We know, for example, that physicians in general are not the entrepreneurial type necessarily that we had,
They want to go home and have dinner with their family.
And they want to be at the
vacations.
Soccer games. They want to take vacations. And that I would argue is a pretty nice thing. It's a pretty good thing. So we as an industry have to adapt to that. We need to be prepared. I mean, that's perhaps one of the things that will make ambulatory surgery centers so much more appealing.
Yes, I agree with
in the
that.
future, because that's what we're geared toward. So let's just kind of recreate some of our conversation there about leadership with our new generation. How do we keep them? And the reason I started the segueing off of what you said is, in the past, we've probably thought, I'm going to train this person and they're going to be with me for 40 years. But now that's different. I mean, and I think we have to embrace it. If it means we only get 2 years out of it, it's better than getting 0 years.
Yeah, especially if they're a good employee. And I think loyalty to the company, they've all seen the boomer parents that got laid off as they got near retirement age because they were getting near the top. If they weren't already at the top of their pay scale, companies let them go before they maxed out their retirement benefits and all of the other things. And they're saying that's not going to happen to me. I don't want the gold watch and a pat on the back.
Yeah.
So I don't have to be loyal. And there are so many books out there about generational differences now. But, one of the differences is that they don't have the loyalty to the companies they work for. Plus, there's not the negativity that used to be attached to changing jobs often is no longer there.
Gone, yeah.
So job recruiters no longer look at that where they had a different job almost every year as a negative.
Yeah.
They may see it as, especially if it's a better job every year, that's initiative. So they look at that as those people they don't sit back and wait for the job to come to them. They're pursuing another job. But it makes it really hard when you're trying to keep a stable staff that understands the culture of the organization. That's getting lost in the shuffle.
Well, and I think that does bring up a good point, because as you said, the employee's loyalty to the employer is very different. But I do think there has been a shift also on the employer's
absolutely.
Loyalty to the employees. I don't know. It's a chicken and egg issue there, I think. But clearly, and of course, we're working with, physicians. We're not, for the most part, we're not working with those big companies out there that have huge resources. So we have that challenge. But, the people that are employing us, the people that are employing those employees, have a very different attitude now than they did in the past. They don't even, today nobody knows what a pension plan is really, meaning something where we're guaranteeing you a certain income at the end. Now everybody has 401ks, right?
They've never heard of it. I mean, the generations I had a pension plan in the early 90s, and in probably mid-90s, they changed it to a 401k. Haven't seen a pension plan since. Yeah. I also have friends that work for AT&T. And they've been retired for 10, 15 years, and they're still getting their full health benefits. Well, is that fair? Well, they think it is because that's what the contract read. Right. But their new employees working for AT&T don't get that. So, there's a whole different perception about employee loyalty and company loyalty to the employees.
Yeah.
Well, I think in our situation in healthcare, the one thing we have going for us is the care, because I think most of the people that go into healthcare care.
Right.
They are
They're
committed.
Not all of us are necessarily in it for the money, to be honest.
Well, that's a definite.
Yeah.
But it's because they want to, take care of people. And if they have the opportunity to take care of people in an environment that takes care of them, that's a win-win. Mm-hmm. So I think that, and I think a lot of the ASCs have taken on that role for a while, but, talk to the staff, find out what it is that they need. If if Ann can't come in till 9 because the kids get on the bus at 8, but she can stay till 4, then do it. You should
You have to be flexible.
Yeah. Absolutely. And that's an important way to look at it because, they might not get the best benefits. And we know that ASCs don't necessarily pay as much as the hospitals and whatnot, but also sometimes the hospitals are more rigid. All right. You might have be under a, what is it? Come on.
Unions?
Yes, thank you.
Well,
right, yeah. So, I mean, some of the hospitals or healthcare places, have unions. So then they stick to certain things, but unions come at a cost.
Right.
As well.
Yeah, and when they go on strike, now everybody loses, and primarily
especially
the patient.
Yeah. But my point being is, so you might pick an ASC that you don't have all that extraneous cost to be a member, but you are able to go to all the soccer games, because then in the wintertime, you don't have games, but your colleague's son plays basketball. So she gets or he gets to go to all the basketball games, and it's a give
Ask
and
yourself
take.
what's important to you.
Exactly.
Yeah.
I always tell when I would be talking to potential new hires, and this is just your staff in general. What's important to you? Because I can help give you quality of life.
Absolutely.
And then you have to really back it up. So sometimes that means you're the one working the shift. Because you promised something and you don't want to go back on that, because now not only do you lose that person, but you might lose another person because they saw that you didn't follow through.
It's so funny that you say that, because when I was a young manager, I said I created a monster, because that's my philosophy. I let people go to their kids' piano recitals, and I let them go to their kids' soccer games and whatever. And we worked it out. And then it became an expectation on the part of the staff. So when I couldn't let them go because our patient volume was crazy and I had just enough nurses to cover, including me and staffing, now they're threatening to call in sick. And I thought, what have I done? Because now their expectation was, well, anytime I want to do something with my family, Ann's going to let me have the time off. I wanted to, but so my solution was to try to get a per diem to come in and work their shift. But I was lucky because I had some really good per diems at the time that were really pretty flexible, even at the last minute. But boy, when some of them would just jump all over me because how awful I was to them, and I'm thinking, where did this derail?
What I would do is I would be pretty open with the staff and say, this is your schedule. If you can find someone to cover you.
Yeah.
And so part of that onus went back on them, and they were really good about it.
Yeah. Well, that's what we ended up doing. But the problem was, get them to assume that responsibility.
Oh, yeah.
And I totally agree with you that they have to. This isn't an entitlement that you get to go to the soccer game. Therefore, if you want to go to the soccer game, it means that much to you. Ann's already in staffing, then you've got to find somebody to cover for you. So
that raises another interesting point, too, is that the power now over that relationship, the scheduling, really has shifted away from us. I mean, let's be realistic here. As much as you've talked about ways to control that, just getting a body in the door sometimes is important. I mean, we've sometimes joked that, the interview is, do you have a heartbeat and a license? You're hired.
And that's the wrong reason
That's
to
the
hire
wrong reason
somebody.
to do it. But that is indeed what's happening in many places.
Administrators are afraid.
Yeah.
They're afraid if they don't hire the first warm body that come fill that slot, they're going to have to fill that slot.
Right.
And a lot of them don't feel prepared to do that or don't want to do that. So they fill it with a body that now 3 months later hasn't worked out, and they're faced with having to let them go. Now you've got a whole other issue to deal with. You're absolutely right.
So there's two things in that conversation. Let's pivot again. Pivoting, I love that term. Pivot to the issue of what do we do when we've made a mistake. And Laurie, you in our company have had the unfortunate job of having to tell management when you've been on site visiting, that maybe that person that you talk to really shouldn't be in that position. You've had actually two situations recently where that you've had that very difficult conversation. So talk about how you handle it, because you're really.
I'm still in therapy for that, John.
I know you
Please
are.
don't bring it up.
But it's an interesting point because in both cases, you were the first person to speak up, and yet it was a thought that many of us had. And in one situation, I'm going to take the blame on this one. I had interviewed that person, and I said, yeah, I can work with this. But you came back and you just said, this isn't going to work out, John. We need to tell the client that.
I don't know. Maybe it's just because, like I said, I'm mean. Remember, guys? Or maybe that was in a different podcast. But again, it's not worth it, right?
Yeah,
it's just not worth it. And you can try to make it work. And sometimes you just know in your gut whether it's going to or not, but you give the person opportunities. You give them every potential to succeed, because that's important, because you've already invested the time, the energy, the money. But sometimes it doesn't work, and you have to be willing to say, I made a mistake. I shouldn't have hired them. Or if you can find a different role for them, which I've had to do in the past with an employee that I hired who was an excellent nurse, just wasn't cut out to be in the operating room. But I was very fortunate that my center also did GI. Mm-hmm. She was phenomenal in the GI center because she was a people person, mm-hmm. and she was able to have that contact that she needed to have with her patients, and she excelled. But I was lucky. That was lucky. And sometimes it's better lucky than good.
My example for that same kind of thing is moving them to a different position. I'm in a center in Florida, and it's one of my centers. I walk by the front desk, or in the business office. They didn't have cubicles. All the desks were open. And I walk by this person who says, I just hate asking people for money. And I thought, what? So I backed up. I said, Chris, what's your job description? She says, I'm the collector. And I said, and you hate asking people for money? She said, you don't know how much I hate asking people for money. But she was a great employee. Mm-hmm. So we switched her with another employee in the business office, and it was like a rose blooming. Yeah. She just came out of her shell. She was happy, and the other girl had no problems with. She was perfect. She'd do it tactfully, was nice to the patients, and got the money. And but you got to do it quickly. You can't you can't spend 6 months to a year training somebody that's not going to work out. You can pretty well figure it out. I work with Sandy C. a lot from C Management out of Orlando. He's an HR specialist. He used to say, cut your losses and cut them quickly. Yeah. He said, so as soon as you realize that, you just call them in the office and say, this isn't working out. If your state allows it, you can let people go like that, and just say, I need you to, and this is your last day. You don't say 2 weeks from now is your last day, because they can do a lot of damage. So you say, this is your last day. Most of the time, they will have known it was coming. Yeah. And they may act like they didn't, but they will. And unfortunately, I've had to do that. It's hard, but you go to their lockers with them, make sure that there's nothing in their locker that they're taking that belongs to the center, and out they go. And try not to embarrass them. Do it at the end of the day or on a Friday. But
well, and isn't it true? Sorry,
no,
Laurie,
no.
But 25 years ago, I had to fire somebody who he was a male who, let's face it, he was a bit of a chauvinist, working as one of only 3 men in the surgery center. It was not working out. He was not happy. The nurses certainly weren't happy. And it was an environment that he needed to move on to. And I can remember, unfortunately, the nurse manager somehow scheduled a vacation when it was time for him to be let go. I'm sure that was purely a coincidence. And it was my job. And I realized when I was sitting down with him, first of all, he was a big guy, so I was a little bit scared of him. But I realized I have an opportunity here to talk man to man. I mean, that's why I said, listen, this is not working for you. You're not happy, right? He says, no. And let's face it, the nurses don't treat you very well because you're not happy, and it's obvious to them. You really need to find another opportunity, something that is going to fit with your belief system, with what you can do. And you're going to be happier, and we're going to be happier here. And I said, unfortunately, I have to let you go, but I'm hoping that you're going to take this and learn from it. The funny end to that story is about 2 years later, I'm boarding a plane at the Rochester airport, and I'm it's one of those small planes that, you walk outside, you have to walk up the steps, and before you walk onto the plane, you have to hand your luggage to somebody. Well, I handed my luggage to him.
You're kidding.
No, I can't make this up. And can you imagine, like, if that, we had a wonderful, 2-minute conversation. I was so happy for him. He was obviously, you could tell he was enjoying his job. And my luggage did get to the destination.
Didn't end up in Japan.
It did not end up in Japan.
Nice.
But that's the thing is that, cut it fast. But also do it in such a way that you said it, Ann, that you save their dignity,
Yes.
you make it as private as you can, and don't, as much as possible, it's never going to be a good situation, but as much as possible, help them to understand where you're coming from and help them to understand it's for everybody's best interest to move on. I'm sorry, Laurie.
No. I years ago when I was in the hospital, I took over, as the board person, running the board in the OR, and I don't know, I became even meaner. And,
Is that possible?
I know. And, I didn't realize that. And, I got called into the director and the nurse manager's office, and they said, we don't think that this is right for you. And, I was crushed, oh my God, how, and I was embarrassed and whatnot. I walked out of that office and I felt like I lost 100 pounds.
Yeah.
I never realized how unhappy I was doing it. And obviously I wasn't doing a good job, but you don't realize, you don't know that at the time. Yeah. And it was the best thing they could have done. And who would ever think that you'd say, thanks for telling me I stink. But it was a really good opportunity and a good learning experience, and now here I am sitting with you, John. I don't know. It's you come full circle, right?
I need to talk to you after this.
And help me.
We'll gang up on him, Laurie.
But it's so sometimes it works for the best, and we don't realize how things are going to turn out until we realize how things turn out.
Well, do all of you listening to this have a plan for your next career? Have you all heard, when I used to go to AORN every year when I was a delegate, and there was a speaker that came out one time and said, every day that you go to work, you should be planning for your next career. So what did he mean by that? Was that as a nurse, you're going to be a manager, or as a manager, you're going to be an executive? Or might it mean if I really could do what I want to do, I'd save money, go back to school and become a school psychologist? I mean, what's in the back of your head? And I think, Laurie, when you're saying you didn't realize what stress that job had created for you, in some cases, you could just land on your feet and say, this is the best thing that ever happened to me, because now I can pursue plan B. And I think that most people don't do that. But if all of us on this call were to sit there and think about what would I do if I wasn't doing what I'm doing today, what a list of possibilities that would open. You could call it your bucket list of careers. It's just amazing to me that I'm still working because I still love what I do. But I love to teach and I love to speak. And so I'm in a career that allows me to do that. But if I wasn't, I'd find something else to do. Right now it's pickleball. For those of I play pickleball and I've just learned it and I love it.
And spent an awful lot of time petting our dog here,
Oh,
right?
I love it. Rosie and I have bonded, let me tell you.
And I got to see Tinker, your
Yes,
doggy.
that's
I haven't
right.
been able to visit with her yet. It's funny, Laurie, you were talking about your experience of being fired. So here's an admission.
I wasn't fired. I was just demoted.
Demoted.
Oh, you were still in the same place.
Yeah.
Oh.
I stayed on circulating and whatnot. It was just that, I didn't have all that other stress, and it wasn't the right time for me. It wasn't the right time for me.
And that's a good, and as you said, you landed on your feet, you moved on. I was actually fired from, one of my first jobs in the industry. Now, the reason I was fired is because I hated the people I was working for. I disliked what I was doing. I didn't trust them, but I didn't see that fast enough. They saw it before I did. And that's, that was a huge lesson I took away from that. And the best thing, it was horrible. It's horrible. Anybody that has been fired knows that it's a horrible thing. It's very difficult on your emotion, on your psyche, because you immediately start thinking of the worst. But, within 24, 48 hours, I had a plan. And I landed on my feet, and I was, by the way, I went on to obviously do many different things over the years, and the job that I took after that, I left because of career counseling. So this is kind of a funny story, and to your point, is that the owners of the surgery center hired a career counselor for the best of intentions. Yeah, they were trying to. It wasn't so much targeted to me; it was really targeted for the nurse manager, and but they wanted me to have different skills to be able to mentor the nurse manager into her future. They felt that she was weak, and they really needed some more skills there. So they hired this career counselor who, unfortunately, was not very good at his job, as I know now. But it was interesting. So I went through this process of identifying what I liked about life, and a couple things came out of it. One is that I had a career in the future as a minister, which of course I am. And another thing is that I did not like being an administrator so much. I liked the consulting side. I didn't like being tied down to one job. And indeed, I liked when things weren't going right. I hate to admit that now. But that's, of course, all I do as a consultant now is I take care of problems. And that came out in the career counseling. So these poor owners who hired a career counselor to enhance my career with the surgery center, 2 months later had my resignation because the career counselor recommended that, basically said, you need to move on. And they quickly fired him, by the way. But that was, as much as that I didn't really like that particular individual, I did learn a lot from it. And it was, of course, a career-changing thing. Yeah. But I like what you're saying there, what your emphasis that no matter where you're heading, it is important that we as employers and you as an employee find things that are going to be satisfying to you.
Well, I always once I discovered international travel in the mid-'90s, quite accidentally, but I went to Paris. That was my first international travel, and I've never stopped since. Been to all 7 continents. So what do I do now? I work in a job where I travel. Mm-hmm. And people say, don't you hate traveling? And I never thought of it till 5 minutes ago when we're talking about this. I love to travel. So no, even if it's domestic, and even if I'm staying in hotels 3 nights a week, I like to travel. It doesn't... There's always places to go that I've never been, people to meet that I never knew. I love to learn. So how do you do things? Oh, you've got a better mousetrap than I have. Let me see how you do that. Yeah. And so it just fits. Those two came together without me even being conscious of it.
Right. And here's another a key takeaway, I think, for all of you out there that are leaders or are in the process of learning to be leaders and whatnot. I found it important to always share with the next person. I still maintain a close relationship with my very first center. And they will reach out to me and ask questions and whatnot, and which is fine. I don't have an issue with that. Unfortunately, my other center is no longer in existence, so we don't have a very good relationship, so to say.
By the way, the one that fired me, by the way, they're gone now too.
Right. But some of the staff from that center, we will still stay in touch, and it's important because you want to keep those doors open, because if you're going to help someone get into that position and either take over for you or, become the leader, then it's really good that they have an anchor. Mm-hmm. And that's who you are as the original leader. You're the anchor. And you might not have the answers, but just the thought that they can reach out to you and you just say, hey, how you doing? I don't know, but maybe I'll try to get that answer for you. That's maybe all they need. Mm-hmm. Just the fact that you're still there, and it's a nice deep breath for them. Yeah. So I found that that's really important. We talked about mentorship and stuff.
And networking. That's why it's so important to network. Yeah. And the 3 of us have huge networks in the ASC industry. Mm-hmm. And I think that what happens is if you're a people person, and even if you're not, you can still have a network. But if you're a people person and you care about what other people do, then when you do lose a job or your center closes or whatever, you've got a huge network out there of people that can help you. This industry is not as big as it seems. Right. I mean, we'll throw out names and one of the three of us knows that person. Yeah. It's just like, because people who are passionate about this industry are involved in this industry. Right. So the biggest mistake someone can make is being isolated and staying to themselves and not going to meetings and meeting people and trying to find out what other people do. Yeah. And then when they would ever need to do that, it's like, I don't know anybody. Yeah, where do I go now?
I was with a new nurse manager yesterday, and one of the things that I said was, I don't know if your center is involved in your state association, but make sure you become involved. Mm-hmm. I don't know if your center is involved with maybe even ASCA, but if they are, then you become involved, because then you're going to have a lot of people that you can reach out to. Mm-hmm. And you might have questions, and yeah, the surgical center next door might not help you, but the one that's 200 miles away might.
Absolutely.
And then you get that relationship and that trust, and you can bounce things off of each other. That's one of the things that, whether you're on ASCA Connect or if you're an endo center and you're on the SGNA talk site, you have people going back and forth with each other. We all have the same questions at some point in our career. And now you get 12 different answers, and one of them might be what you're looking for, or you can mold it to help the situation that you're in. So, don't feel like you're alone, because I know you do often feel that way, but it's hard. So, reach out and yes, network for sure.
Well, the two boot camps that are coming up, the nurse managers and the administrators boot camp, you will have an opportunity to network. Mm-hmm. We will be sharing information and asking for your permission to share contact information. I taught in the AURN Administrators Skills Camp for years, for 20 years, I think we talked about today, and still do, although with COVID, it's all virtual now. Yeah. But at the end of every course, people would get together and exchange emails, and then they create a group email. That group email would go out. Some of the other instructors, because the instructors were all included, would say, what am I getting these emails from? And I said, because you remember that email sheet we said we would participate in? Though that relationship still goes on today with many of those centers, or those people that participated. Don't undervalue that. So if you haven't signed up for the boot camps, get your little self signed up right now, because it's going to be that important.
Well, and we are going to continue the boot camp. So we have the administrators boot camp coming up in August, the nurse managers boot camp. I don't know when this recording is going to go out. It might be filled by that point, but we will have another nurse managers boot camp if I can convince Laurie to dedicate another week of her life to it. And we're also going to have, so there is, in addition to the boot camp in person or virtually, 4 days in August, we do have a self-paced administrators boot camp also that's available now. And again, all on our website at ascpodcast.com. But I wanted to, we talked about in the beginning how there is no, I can't remember if we talked about it here or not, but there is no college on how to become an administrator.
No.
There is no college course on how to become a nursing director in a surgery center. And it's not likely that that's going to happen anytime soon. So that's why things like the boot camp are important. But as I've said before, it's not enough. I mean, the reason the boot camp is important because we often don't have the opportunity to mentor somebody. Let's face it, the best way to do this, the best way to develop an administrator or a nurse manager is to find somebody and spend, literally a couple years. Yeah. It's got to be a couple years. It's not something you learn right away.
And even if you separate, you continue that relationship.
That's right. Mm-hmm. So I think I just want to kind of end here, and we're already inching up towards to an hour here, by the way. I do want to end by talking about the importance of mentoring. And granted, it's not going to work in all places, especially when we know that the longevity of many of our employees are not going to be very long. But let's just talk about ways that we can mentor, even if it's for a short period of time. And I want to emphasize not only mentoring leaders, but also the employees that come in and our staff.
Well, first of all, I want to comment on, Laurie made the comment about choose your preceptors carefully. Yeah. That's one of my pet peeves, is that the preceptor and the person being mentored, the personalities don't match, and it's just like oil and water. But I think once you've identified a good preceptor that goes to the mentor, they become their rock. That's who they go to with everything, and they can share. They need to have that trust that whatever they share with their preceptor something's going to be done about it. It can be that when I'm in this room, X treats me like dirt, or when, I don't think sterile processing is doing the instruments correctly, whatever it is, that person trusts you. But teaching them the correct way to do things, and letting them know that the patient always comes first, that in our centers we do work very quickly, especially if we're in a quick throughput center. That being said, we don't short the patient any care. That patient's not being shuttled out the door. Like I used to get when hospital nurses would come to my centers and they'd say, this is unsafe patient care. You send them home way too quickly. Ask the patient instead, who comes out of surgery, they've been fast-tracked, 20 minutes later, they're ready to go home. The next day on their call said, I'm so glad I was able to go home and get my own bed. Look at the take on that. One nurse is saying this is unsafe care. The patient's saying that's the best thing you did. So how do you mentor that? You teach the patient in pre-op that we're sending you home quickly so that you can recover at home quickly. And if you want to watch TV, you're in your own home or read a book or whatever. Let them know that's the expectation. They're not going to feel like they got rushed out the door.
Right.
So
if they know that was the purpose in doing
that's right.
that.
Exactly. Not that it's because you don't have enough beds and you're just trying to get people out of here. But I think I love to mentor people. Once you've assessed their level of skills, then you pick up on the skills they already know, and you don't need to do a lot of reinforcement. They got it. But what do they still need help with? And constantly dialogue. What do you need help with? What have you not seen that you need? And part of that should be on the orientation checklist. What has somebody not shown you? Oh, they didn't show you how to use the C-arm, or, well, that might be big if you're in orthopedics, and then the doctor's yelling and screaming at you. And so anyway.
Well, one of the big things, too, is that your mentor might not be a colleague from the same playing field. Your OR nurse can learn a lot from the surgical tech.
Absolutely.
Good point.
So, there's also that. So you might want to take the tech to mentor the new circulator on what we open. Here's our preference cards. Here's why we don't open. Because when you come from a hospital, I think I still have blue towels and sheets, because we opened so much waste. And back then, you were allowed to take it, because we didn't have, there was no such thing as infection control back then.
Too bad you didn't take an awful lot of like masks at that time.
I know. If only I'd known. But that's
or toilet paper.
Yeah.
But your suggestion about that.
Yeah.
Because when I entered the operating room years and years and years ago, my mentor was a surgical tech. And after I read the policy manual, they put me with, her name was Ginger. They put me with Ginger and I learned to scrub. And I became one of the best scrub nurses they had. It was a hospital in those days. Best hospital scrub nurses in there. And then we were married and I was pregnant and started getting sick when I was still on my feet. I had to circulate. I never ever loved circulating like I love scrubbing. But that surgical tech taught me the right way to do everything.
Correct. So again, you know your staff and pick your champions, and they're just going to have they're going to create your new champions.
Yes, absolutely.
And that's all from within. And then, you might see someone that is going to rise to your level or to your position, or, you might be upgraded, or if it is such a thing, to administrator, given more headaches.
Sentenced, I think.
So now you need a new nurse manager. Well, you've probably got a handful of really good candidates. And so hopefully you've been nurturing them along so that they can step into that position, and you're right there to help them. So it's just stuff like that, but then you also have to know your audience. Is the staff going to accept that person? Unfortunately that's key too, because, then you don't want a rebellion. You might have someone that you think is the best, but if they don't get along with 3/4 of your staff or all the doctors dislike this person, so, you've got to take everything, look at the whole picture, not just, as John said before, not just a warm body. And I'm not saying that your employee is a warm body, but you don't want that same situation even when you're hiring from within.
Right.
Yeah.
Well, this has been fantastic. Thank you so much for joining us here. I know that...
Can you take the handcuffs off now?
And we're never at a loss for words.
No, we aren't. I was worried. Are we going to fill in, 20 minutes and we're at 52? But I really appreciate your taking the time. We're certainly going to do this more often. Unfortunately,
so.
We're not always together, certainly,
No.
but we have other ways of doing it. And it is, I will just say,
fun.
having you guys as colleagues in this industry is really what makes
So
it
it
all
makes this
worthwhile.
industry great.
It is.
Yeah.
So thank you for your time.
Oh,
Thank
you're
you.
welcome. Thank you.
In this segment, we discuss other learning opportunities in the ASC industry. If you would like your event to be included in the podcast, please send the event information to info@ascpodcast.com.
So as we mentioned earlier in the podcast, the ASC Podcast Infection Control Oversight 101 will be this coming Friday, July 23rd, 2021. And Infection Control Oversight 201 will be on Monday, July 26th, 2021. For more information, go to the ascpodcast.com or follow the links in the show notes. And it's important for me to note, while we were recording here, I got a phone call from somebody that is signing up for both of those conferences, and they asked me if they will have access to the recording afterwards. And I don't know why I'm not getting that point across, but it is included in the information there. But I'll state
And
it
we've
right
had
here.
several questions too. I don't want to put this on
people.
her.
No.
We've had
I was
everybody's
joking. I just don't know
asking.
what I'm doing wrong. It's clearly me. It's clearly I'm making a mistake here. But we do want to emphasize that even if you can't attend any of the conference on Friday or Monday, sign up for it anyway, and you'll have full access. And then we will also be selling it later on.
Yeah, because it's so rare when somebody can actually take the time to just sit and listen the whole time.
That's right.
You're always going to get pulled out.
I think it's only you and I and Laurie that are able to do that. And even you and I sometimes have to take some time away.
Yeah, our dog Rosie, she comes and bothers, I got to go take her out. So the Administrators Bootcamp, the August cohort, is August 17th through the 20th. It's a 4-day virtual conference, including other benefits such as books, access to our database, and weekly drop-in sessions.
And Sue, we are having so much fun with those drop-in sessions, too. I do want to emphasize. So that if you are a patron member of the podcast, you have access to these drop-in sessions. But all of our Bootcamp members, since the beginning of time, I don't know when we'll eventually cut that off, but all of them are able to access this weekly drop-in, and we have a lot of fun during it.
Yeah, we haven't had a whole lot of people join, but Laurie's been coming into a lot of times.
Yeah.
And I'll tell you, the ones that do join, they have really good access to you guys. They have a lot of good questions. And we learn from them, and they get to learn a lot from you. So it's a great opportunity.
And so here's the other kicker, is that they have been passing their surveys with flying colors. So there you go.
Yep. And the AORN Expo 2021 is August 7th through the 10th, 2021 at the Orange County Convention Center in Orlando, Florida.
And we had hoped to attend the one in 2020, but of course that didn't happen. So we're not going to be able to go to this one here, but we will talk in the future about trying to get to the 2022 one. And our friends over at the California Ambulatory Surgery Association have their 2021 annual meeting, which is going to be September 8th through the 10th, 2021 at the Hyatt Regency Huntington Beach Resort and Spa in Huntington Beach, California. And Sue, it does look like we're not going to be able to go to it, unfortunately, just because of the logistical issues of getting across the country. And, it doesn't look like it's going to be possible with our equipment and car rentals and all of that. So we tried, but...
we do. We really enjoy it. So we've just been kind of saying, we're going to be there. But then when we really sat down and looked at it, just with the schedule and everything. So
and
we will try again next year.
It is going to be very expensive for somebody that's not, from the state of California.
Yeah, just to get there. And the Illinois Ambulatory Surgery Center Association's annual meeting is in September the 22nd at Sheraton Lisle Naperville Hotel in Lisle, Illinois.
And the Ohio ASC Association's conference will be at the Hilton Columbus Polaris on September 27th and 28th. And they're going to be hosting this 2-day event featuring an exhibit hall and 2 full days of education. And I am honored to be their keynote speaker this year.
That's a great conference. The New York State Association of Ambulatory Surgery Centers live and in person Roaring Twenties conference will be held at the Sleepy Hollow Hotel and Conference Center in Tarrytown, New York. That's a Beautiful
It's a beautiful
place.
site. And you and I, well, we love Terrytown anyway, just as a vacation spot, let alone going for a conference.
So for more information, visit nysaasc.org.
And we should note that it's September 29th and 30th. I think we forgot to mention that.
We did, yep.
And we're going to have a very heavy presence there. We're going to have our own podcast room. We might record live. Hard to tell at this point as we're trying to figure out the technology. Unlike California, we will be able to drive there, so we'll have our full studio equipment. And the Washington Ambulatory Surgery Center Association's annual education conference and trade show will be November 4th through 5th, 2021 at the Tulalip Resort and Spa in Tulalip, Washington.
The Pennsylvania Ambulatory Surgery Center Association's annual meeting is November 8th, 2021 at the Hershey Lodge in Hershey, Pennsylvania.
So that's it for this episode of the ASC Podcast with John Goehle. Join us again, and please consider becoming a patron member by going to our website at ascpodcast.com and spread the word about our podcast with your friends and colleagues, and do us the honor of hitting the subscribe button. Also remember, the patrons of the podcast get a lot of different benefits, including access to a database, these weekly drop-in sessions that we sponsor, and just access to us, much higher access than you have just by listening to us, and it's a very reasonable monthly cost. The sound editor for this episode is Susan Cronkite. Executive producer is John Goehle. Research assistance is provided by Susan Cronkite, Jenna Alvarez, Judy D'Ambrosio, Alex Borneman, Zach Calritis, Amy Girbano, Laurie Roderiques, and Ann Geier. Music is provided by Media Sushi and Mike Noah, and the ASC Podcast with John Goehle is hosted on Podbean and is available on all major podcast channels.
We would like to thank our sponsors, Surgical Information Systems, providing cutting-edge information solutions for surgery providers, and Ambulatory Healthcare Strategies, the nation's leading regulatory compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com. This podcast has been an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.